should be estimated. What are the components which are excised? Only the lining was excised, our outer skin was also excised, our bone was also excised, or in combination defects are excised. And what are the compartments involved? It is orbital, maxillary, and mandible. All these things have a bearing of the choice of flap which is used to reconstruct a defect. If the defect has only lining defect, then there can be free radial forearm for that. If patient need extensive soft tissue coverage and bulk, for that ALT flap is the flap of choice. And if the bone is involved, then free fibula flap can be harvested. And for venous anastomosis in the neck, at least one artery and one vein is prepared for microsurgical anastomosis. And after the vessel preparation, irrigation with vasodilators should be done, and it should be covered with the heparin impregnated gauze. And after flap harvest, flap is partially inset into the defect to ensure its proper positioning and reach of the pedicle to the recipient vessels. Watertight closure of defects is very important because it will prevent the formation of orocutaneous fistula, which will further cause infection, which may have disastrous consequence, even the flap failure. Most inaccessible areas are sutured first, and inset partially are largely completed before microsurgical repair of the vessels. The most common recipient arteries in neck are the branches of external carotid system, that is facial artery, superior thyroid artery, and lingual artery. If these are not available, then less commonly superficial temporal artery and transverse cervical artery may be chosen, but the flow in these arteries are not as robust as in previous ones, and the diameter of these arteries are also less than the commonly used recipient arteries. Most common recipient veins are common facial vein, superior thyroid vein, and external jugular vein for end-to-end anastomosis. If these veins are not available, then internal jugular vein can be used for into-side anastomosis. One particular attention to the drain placement. Drain after completion of microvascular anastomosis and all of the surgery should be placed in the dependent portion of the wound. It should always be away from the site of microanastomosis, and it should usually be placed in posterior triangle of neck. Any negative suction should not be applied in the area of anastomosis because it will compromise the patency of anastomosis. After the procedure is done, post-operative care is as important as the procedure itself because it will be a bearing on the success of this procedure. Patient positioning is very important. If, for example, if anastomosis is done on right side of neck and patient head turned too much on the right side of the neck, then the pedicle may get kinked. And if the patient neck position is on the left, then the pedicle may get stretched. So pedicle positioning is very much important. Vital monitoring in all surgical patients is important, but here hydration and hematocrit takes paramount importance. And hematocrit should be maintained by between 25 and 30%, and blood transfusion, decision for blood transfusion should be governed by that. Most critical during monitoring is during the first 24 hours in general and up to 3 to 5 days after surgery. In first 24 hours, there should be nothing by mouth and patient should be on a strict bed rest so that if re-exploration is needed, patient can be shifted immediately to OT without delay. Tracheostomy is commonly done in head and neck malignancies, but there should not be any tracheostomy ties after these flaps, even after placement of pedicle flaps. Flap monitoring is done. Our protocol is to do 2-hour flap monitoring for the first 24 hours for pin-prick method. On pin-prick, this bright red color in 2-3 seconds will tell you about the well-being of this flap. Anticoagulation protocol is different in different institutions. We initially followed the protocol of continuous heparin infusion, but in view of the complications like more bleeding, we switched to the Claxane, single dose in 24 hours, and the outcome has not been different. In terms of success of the free flap, options of reconstruction in head and neck surgery will be based on what is needed to cover the defect. If the goal is, if there is soft tissue defect, soft tissue coverage should be there, intraoral lining should be reconstructed, and if there is bone dissection, proper vascularized bone is provided. For lining and soft tissue reconstruction, there are a plethora of flaps. But two flaps, anterior thigh flaps and free radial flaps, are called workhorse flaps because they can cover any defect in head and neck region. Quality of ideal soft tissue free flap for head and neck reconstruction, that the flap should be versatile in design. It should have adequate tissue stock. It should be of superior texture. It should have minimal donor side morbidity. Availability of diverse tissue types on one pedicle should be there. It should have potential for re-innervation. It should have large and long pedicle, and feasibility of two-team approach should be there. And most importantly, consistent anatomy for an easy and safe flap dissection. ALT flap, anterolateral thigh flap, has all these quality except the consistent anatomy part. ALT flap is the most commonly used flap for soft tissue lining. It was described by Song from China in 1984, and it is based on descending branch of lateral circumflex femoral artery. As I already mentioned, there are anatomical variations reported in this flap. This flap is marked from anterior superior iliac spine to the superior lateral border. This particular line will be the septum, and a 3 centimeter diameter circle will be drawn in the middle of this, which will show the location of perforators from this descending genicular artery. After giving incision, rectus femoris muscle is retracted, which will show the pedicle of this descending branch of lateral circumflex artery and the perforator which arrives from this. In this picture, the perforators and pedicle are dissected from the structure, and the flap is raised over this pedicle. Another important flap is free radial flap. It was described by Yang et al. In 1981, again from China, and this flap is popularly known as Chinese man flap. This flap is based on radial artery. LN test should be performed before raising this flap. LN test is a test which tells you about the dominance of vessel in hand. Rather, ulnar artery is dominant or radial artery is dominant. And this is the marking of the flap. Flap is the center over the radial artery according to the size of defect. Then radial side dissection is done to expose the septum. Cephalic vein encounter should be included in the flap because this is the vein which will be used in the flap venous anastomosis. Finally, after retracting the brachioradialis tendon, septum is revealed. Then distally radial artery is identified in septum and ligated, and flap is raised distally to proximally on the pedicle, and whatever length of pedicle is needed, it should be restricted off. The advantages of free radial flap, that these are very pliable and thin skin. The flap may be fairly large, 13 into 15 centimeter. It can be raised as a multiple skin island flap. Sensory innervation is also possible, and this flap can incorporate radius bone or tendon. But the major disadvantage is the donor side morbidity. Because the tendons are exposed, so the donor side coverage of graft always takes off. So donor side morbidity is there, and if there is need of tissue stock, this flap lacks in adequate tissue stock because it has a very thin and pliable skin. For bony reconstruction in head and neck region, there are multiple flaps like free fibula flap, circumflex iliac osteocutaneous flap, scapular osteomusculocutaneous flap, and radius with radial forearm flap. But the free fibula flap has become the standard of choice for mandibular reconstruction because it is a bicortical bone flap. This flap was initially described by Taylor in 1975 as a bone-only flap, but it was become popular after Hidalgo reported in 1989 for reconstruction of 12 mandibles. Till 1994, this flap was raised as only bone flap. Fu Chen Wai from Taiwan in 1994 described the osteoseptocutaneous flap. He described that a skin island can also be taken with the bone flap. This revolution made this free fibula flap as a standard flap for mandibular reconstruction because you can simultaneously reconstruct lining, bone, and a small area of external skin if needed. This flap is based on peroneal artery. There is a phenomena which is called arteria peroneum magna, and this phenomena is present in around 12 to 13% of patients. This condition is important to assess because in this condition, peroneal artery in the limb becomes the dominant artery. And if this flap is harvested based on this peroneal artery, then the limb vascularity will be threatened. So before harvesting any fibula flap, color Doppler and proper clinical examination should always be done. These flaps are based on the septum, which is present below the posterior border of fibula. After subfacial dissection, we can observe in this third flap there perforator going in the skin, which will supply the skin island. After dissecting the lateral compartment and anterior compartment of the leg, interosseous membrane is cut, and after dividing tibialis posterior, pedicle can be identified and flap can be raised on this. So microsurgery has brought too much options and functional restoration in case of head and neck reconstruction. Now I will discuss our experience here in AIIMS Jodhpur. From January 2019 till now, there are 45 free flaps done in head and neck reconstruction, in which 21 were soft tissue flaps and 24 were bone flaps. If we dissect it according to the type of flap, then ALT flap was done in 13 patients, free radial forearm flap was done in 8 patients, and free fibula flap was done in 24 patients. In 3 patients, simultaneously, 2 free flaps were done because of the requirement of the defect. And in case of another flap failure, in 3 patients, free flap reconstruction was done as a second operation. During these COVID times, after lifting of the lockdown and resuming of the semi-essential services, we have done 15 free flaps in 12 patients, in which 7 were free fibula, 6 flaps were free ALT, and 2 flaps were free radial forearm flaps. We have our share of complication. Total re-exploration were done in 8 patients, in which we were able to salvage 4 flaps. Flap failure were in 4 patients. In 6 patients, orocutaneous fistula was developed, which was transient in nature and healed by conservative management. There were no instances of plate exposure in any patient. Donor site complication, which required another surgery, happened in 4 patients. But the long-term donor site complication was not identified in any of the patients. Here are a few case examples. This is a patient in which there was a malignancy which involved inner lining, mandibular bone, and the outer skin defect. Fibula flap is raised and the defect is repaired. We can appreciate the contour of mandible after even excision of this bony section and the formation of this external skin island. Another patient in which mandible reconstruction was done by free fibula flap. Again, the restoration of aesthetic contour and the functional aspect is full in this patient. This is a patient which is operated during these recent times, in which the defect was too large. There was malignancy of central segment which involved the skin also. So 2 separate free flaps are done in the same patient, free fibula and free ALT, to cover this extensive defect. Another patient which was operated recently, 2 free flaps are done in the same patient, free fibula and free ALT. And post-operative patient's oral competence and the cover of the defects are in satisfactory condition. Another patient recently operated, fairly large defect of intraoral lining and external cover. A big ALT flap, 13 into 18 centimeter, is taken, and both intraoral and external defect is covered in a satisfactory way. Another patient in which there was defect of the upper lip only. Free radial forearm flap is used to reconstruct the upper lip defect. So these were the experiences of our team in microsurgery in head and neck reconstruction. Now we move on to the panel discussion on this topic. My first question to you, Dr. Jeevan sir, as a head and neck surgeon, what are the differences in outcome you found in head and neck reconstruction done with the free flaps or the pedicle flaps?
Generally, it is considered that whenever you reconstruct with a microvascular flap, then all this functional outcome is better in comparison to the loco-regional flap. However, it is difficult to compare these two distinct flaps, but there was a recent published systemic review which has shown that surprisingly that there was a not significant difference in many aspects of the functional outcome in the free flaps in comparison to the, and in that study also in that some patients or some studies they have shown that speech is better in the free flaps, and in another some studies they in RCTs also they have shown that it is better with the, so but generally because you have freedom to reconstruct any amount, any extent, and you can replace bone with the bone, soft tissue with the soft tissue, so that freedom is not with that loco-regional flap. So it is always preferable and it is considered gold standard.
In your opinion, what is the impact of microsurgery in head and neck cancer surgical resection and management because of these free flaps?
Because of these flaps, because whenever primary head and neck surgeon whoever is operating, then he don't need to worry about that whether he will be able to reconstruct or not. So otherwise he may compromise the margins while keeping in mind that I have to reconstruct this. Because for oncological outcome, you have to have adequate margins. So you have that kind of freedom because head and neck area is a limited and it is a difficult area. So you don't have other options like in at other sites like for breast or trunk. So therefore, there is a freedom that you can resect any extent of the resection. Like you have shown very well examples in that we have resected a large part of the skin or bone and everything, and you were able to reconstruct this with the either with the large single flap or large double flap. So,
Sir, how did COVID-19 situation influence the management of head and neck cancers?
COVID-19 situation affects because basic principle during this COVID-19 that whatever kind of you are surgery doing, that should be less morbid. Patient can be discharged early or with the minimal or sort of stay in the ICU and the hospital. That principle is being followed for every kind of surgery. So same lies here that in that situation, because if we are going to do a reconstruction with free flap, because it will require a longer ICU stay or somewhat, so or hospitalization. So in that, but even despite these, we have done a good number of free flap in our department along with the Dr. Pawan and Dr. Prakash Wala. So and we were taking all the precautions while to prevent the perioperative COVID infection. We were doing twice COVID test before surgery, like at day 1 and day 7. So because of this, we were able to, at least till now, we have not seen any mortality due to COVID positivity.
Thank you, sir. My question is to Dr. Kapil, sir. How do you approach a patient with head and neck malignancy?
Good morning. To approach a patient with head and neck malignancy is tricky because you are dealing with an area where there is going to change in the way they swallow, the way they breathe, the way they speak. So it has a huge role on the psyche of the patient post-operatively, how it doesn't depend how do you reconstruct, but it's going to change. So first of all, to approach a patient with head and neck malignancy, there is a need to break the bad news. So it is regrettable that most of the patients who came to us with a diagnosis of malignancy, that they were very angry the way the news was told, that you are suffering from cancer and nothing I can do. So we should avoid that. So when I am going to disclose the patient that just you are suffering from malignancy, I take time in a quiet room where there should be no interruptions and there should be a perfect confidential. There is a perfect confidence will be there. Patient should have perfect confidence in me. And we should make the patient, because when you're going to break the news, patient and the relative, they may feel that they are helpless and they are abandoned. Like, we should not let the patient this. So when we are there to break the news, we should make the field understand that we are there for them. Their life is worthwhile, and we will be doing as much as we can for their medical as well as surgical needs. This is regarding the breaking the news. So first of all, confidence of the patient. Second is how we will go further. Regarding reconstruction, now the concept is quality of life. And we should tell the patient, we should give the options, because it is the quality of life that matters. It's the survival is there, but nowadays it is the survival plus quality of life, and the patient is right to choose it. Because either you are doing radiotherapy, surgery, or combination of both, there is going to be a huge toll on the quality of life post-operatively. This is basically true when there is a defect is big, defect is large, because patient is going to be, the look is going to change, the way they are dealing with the daily functions is going to change, and there are going to be long hospital stay. So our first and foremost is that patient should be comfortable, they should have good options, they should have an understanding that this is a huge disease and there is going to be a big change in their life. And one more thing which is particularly true for our countries, there are a lot of myths and misconceptions that are related to this head and neck cancers, that because most of the patient, their relatives or someone else, they take them to some desi treatment and some sort of tabeez, and we should make the patient understand this is not going to help them. It is only going to make the problem worse. And it has happened that patient who has been diagnosed stage 1 and stage 2, they finally landed us in stage 4. Yes.
Yes, sir. Another question is certainly, how does a frozen section help in better outcome of head and neck malignancy?
Frozen section is very helpful, and I would like to thank Department of Pathology, because they have been very helpful to us. Whenever we have asked for frozen section, they have come up and were provided with very important inputs, because frozen section will make you you will be very confident that yes, you have taken out the margins very well, because whenever we take out the specimen, the margins we specifically take out and send for frozen section. If it has come out to be yes, the margins are clear, then we are sure that yes, you have taken out the tumor. Else we can just take out a bit more and then send the patient, send the specimen again for the frozen section. It will basically preserve as much specimen as you can, and this is going to be very beneficial for the further reconstruction of the patient.
So, what are the additional precautions that should be taken while operating in head and neck region in these COVID times?
In this COVID time, as Dr. Jeevan Ram has told, that we are taking up a lot of patients with malignancy. We have significant number of patients has been operated. One more thing in our department is that we are getting a lot of patients with stridor because of the malignancy. So the precaution is we get the patient tested for COVID with rapid antigen test, although it is not very informative, but still we are going to do it, and with all due precautions. We are taking the patient to tracheostomy and DL examination. That is for the tracheostomy part. No patient is denying any treatment, although the report is pending, but we are still taking the patient with full PPE and full precautions. And as Dr. Jeevan said, for elective patients, we take RT-PCR test twice. That is most important for head and neck, especially head and neck patients. And then these patients are being operated in our departments.
Thank you, sir.
Thank you.
My question to Dr. Prakash sir is, what are the different methods of flap monitoring?
Very good morning. Flap monitoring is a very important part of the post-operative management of the flap cases, especially in initial 48 to 72 hours. There are different methods of flap monitoring by which we can see whether a flap is compromised or it's okay. Like on clinical examination, healthy flap is warm, turgid, and scratch on bleeding present. Capillary refilling is another example. If on the this scratching or pin break, if the dilated bleeding is coming within 4 to 5 seconds, then it is okay. If it is a on pin break, if the blood is no blood, then definitely the flap is compromised from arterial side. And if there is a brisk bleeding with dark color blood, then we can say that there is some issue related to veins. That is venous congestion is there. Now there is a important recent addition in this flap monitoring is intraocular Doppler monitoring. It may be, and we can see that signals from the vessels coming or not. It may be implantable Dopplers or it may be an external handheld Doppler we can use for flap monitoring.
Sir, what are the options, what are the points to consider while choosing a vessel for the anastomosis?
While choosing an appropriate vessels for the anastomosis is a very important part for the success of the flap. Factors which are important that size of the vessels. Same size vessels are best for the end-to-end anastomosis and have a good results. While if there is a disparity in size, there is some chances of kinking or some problem at the suturing maybe there. So which these factors, if there is not appropriate suturing is there, so this may leads to post-operative thrombosis formation at the anastomosis sites. Another is the orientation of the recipient and donor vessels. If the flap vessels are in orientation in line with the recipient vessels, then there is high chances of flap success, and there shouldn't be any kinking. We should try to avoid any kinking post-operatively, and definitely flow is very important factor in head and neck surgery. Flow is good in facial artery, superior thyroid artery, so there is no issue in head and neck surgery as far as flow is concerned. It's an important factor in the lower limb, which is affected sometimes by the peripheral vascular diseases. Another important factor is the consistency of the anatomy, which vessels which have a consistent anatomy, which is easy to find and helps in the appropriate anastomosis and timely anastomosis. So these are the factors.
Another question is that pre-flap failure occurs less commonly, but they do occur sometimes. In that event, what should be the protocol of further management?
Yeah, pre-flap has a very high success rate. I mean, in different centers, it's almost 95% success rate, and initially it may be a decrease, but gradually it improves with the time as the experience goes on, and as the sorry.
What are the protocol? What should be the protocol of further management after one flap is lost?
Yeah, if we lost one flap, then the two options we have: either go for a local flap or either go for a secondary free flaps. Depends upon the patient-related factors, how the patient is conditioned, because patient cannot stay long distance surgery. Some patients, we should avoid free flaps in these cases and should go for local flaps. Definitely, there are problems with local flaps, which you have mentioned earlier, and free flap. And our experience and from the different literature, free flap is the best options for the second choice as a second choice. But we have to see so many factors: patient-related factors, and setup-related factors, and the surgeon-related factors.
From the reconstructive point of view, how did this COVID-19 era change the head and neck surgery?
See, primarily a patient comes to the operating surgeon. So how the delay in the size over that period, size of the tumor is grows. It's a matter of outside the field of plastic surgeons, because whatever we got after the resection of the segment. So what is the progress of disease from these durations? It's not in our hand, but yes, definitely our experience says that we have harvested flaps uses flaps which are more complex, and we have to use larger flap, or some defects are so complex that we have to use two flaps, as you have mentioned in your presentation. So definitely these are the things which we noticed in that complex defect was large size and defect was more complex. So these are the factors as compared to pre-COVID area. So we can say that yes, definitely there is an increase in the size. Relatively we find as compared to pre-COVID area.
Thank you very much, sir. And thank you everyone for the patience listening. Thank you.
They have a question.
Okay. Sir, no, we do not have any case of dynamic tongue reconstruction as of yet in AIIMS Jodhpur. And if we get any case of that total glossectomy defect with tongue mobility, we can think of some dynamic tongue reconstructions. Recently, one option was there that a free ALT flap along with the neurotized vastus lateralis muscle was taken for giving the movement of tongue after the reconstruction. But as of now, we have not encountered these cases here. So if there is no other question, then we can end this CGR. Thank you very much.